Welcome to this myelodysplastic syndrome, or MDS Phone a Friend series, where you'll have the chance to listen in on your peers discussing common clinical challenges in the management of lower-risk MDS-associated anemia. Check back frequently to tune into episodes in the series that cover topics such as diagnosis and classification of MDS and management of patients with lower-risk MDS who would benefit from an individualized approach to pharmacologic treatment. Today, Dr. Andrew Kuykendall is getting ready to see Margaret, a patient with lower-risk MDS with isolated del5q, and he has some questions for his colleague, Dr. Aditi Shastri.
Hey, Dr. Shastri, sorry to pull you out of clinic. Hey, Dr. Shastri, thanks so much for taking my call.
Of course, it's my pleasure, Dr. Kuykendall. What do you got?
Yeah, so at this time, I want to tell you about a patient of mine named Margaret. So she's a 75-year-old woman. She's got a history of hypertension, coronary artery disease. She had an MI 10 years ago, and she has some CHF with a 3-year history, really that I've been dealing with, of low-risk MDS and isolated del5q. 2-year history of red blood cell transfusion that really have increased over the past 12 months. So now she's getting 2 units every month. And this really leads to repeated fluid overload and hospitalizations, really exacerbating that CHF. Her serum EPO level's 450. Her hemoglobin really remains between 8.5 and 9.5 with these transfusions. And otherwise, she has a normal platelet count. Well, what do you think? I mean, it's a tough case for me. I was just wondering, what do you think would be your preferred treatment approach for Margaret?
So thank you so much for sharing that case, Dr. Kuykendall. So she has MDS with a deletion 5q, and this is a very specific type of MDS. So these patients with the deletion 5q and low blasts and lower risk myelodysplastic syndromes have a few different therapeutic options. I like the NCCN algorithms, sometimes to look at them, and they're actually accessible to everyone, patients to physicians. And one of the things you'll see when you look in there, and the thing is that the patients that have the deletion 5q, or it could be even one other cytogenetic abnormality, but except for monosomy 7 or anything involving the chromosome 7, and have lower risk MDS by IPSS, so lower intermediate 1 risk MDS, we kind of end up also looking at a few other things. So you told me about her serum EPO level, which sounds relatively high. The really preferred option in this case would be lenalidomide. Lenalidomide is an immunomodulator. It is in the same class of drugs like thalidomide, which, as we know, is a therapy for multiple myeloma. And this is a time-tested therapy for MDS with deletion 5q.
So what factors do you consider when deciding between ESA or lenalidomide as first-line therapy for these del5q MDS patients?
This is a very good question, and I will say that, we always get serum EPO levels on all our patients, and our European colleagues, have come up with a very important score, the Hellstrom-Lindbergh score, and over time this has also been revised. And this really, the crux of the score is really looking at the transfusion burden of the patient and the serum EPO level. And based on this, we kind of can predict a probability of response to therapy with erythropoietin stimulating agents. And if you have a very good score or a good score, typically these patients respond well to standard therapy with erythropoietin or ESAs. But patients that have a worse score, like intermediate or worse than that, really don't respond very well to ESAs. And a lot of the score is really driven by the fact that these patients have higher EPO levels and a higher transfusion burden. So this is something that we can use if we want to decide if patients are good candidates for therapy with ESAs. moving forward, I think, of course, in this case, overwhelmingly, you would decide that you want to put the patient on lenalidomide, given that you have this data that the patient has a deletion 5q. Some other things we can think about are patient preferences and comorbidities. Given that lenalidomide is a therapy that is oral, so, given that it's in a pill form, a lot of patients might prefer this versus having to come in for weekly EPO injections. And sometimes there are some side effects that patients are a little bit averse to. So the one thing I face commonly in clinic with lenalidomide is GI side effects like nausea, diarrhea, and some patients may be more sensitive to that than others, but typically we can manage this quite well with supportive therapy. So I want to actually discuss a very interesting study that came from Europe and was presented previously at ASH called the Sintra-Rev study. And I think what we have recently explored is, can you potentially start lenalidomide even before the patient becomes transfusion dependent? So Dr. Kuykendall, I feel like maybe you could consider this for your other patients that have MDS and are not yet transfusion dependent, but this phase 3 study looked at lenalidomide versus placebo for the treatment of patients with del5q, low-risk MDS, and anemia, but these patients did not have transfusion dependency as of yet. And the findings of the study are fascinating. What they actually found was that the lenalidomide treatment did prolong the time to transfusion dependency from the beginning of the treatment, and this was by a large amount of time, so 66 months versus 11 months. And it improved hemoglobin levels, so 70% of patients had an erythroid response. And it really had a pretty good safety profile. There were no major adverse events, and there was no increased progression rate to MDS or leukemia or clonal evolution of the disease.
So would you ever consider something like a combination of lenalidomide plus ESAs?
This is actually a great question, and this has been studied before in a few different studies. And one of the interesting things to note is if you look at erythropoietin or erythropoietin stimulating agents, they work very early in the erythroid development stage, so when it comes to the erythroblasts or the erythroid progenitors, they work on the very early stages of these. So it is ideal for looking at combinations of ESAs with lenalidomide, luspatercept. In this case, let's go ahead and discuss lenalidomide. There was actually a study with Thoma et al. In 2016 where 131 patients that were transfusion dependent, low-risk MDS, and ESA refractory but non-del5q patients were given lenalidomide monotherapy or lenalidomide with erythropoietin. And what we found was that the hemoglobin or the hematologic improvement in the erythroid lineage was 23% for monotherapy versus almost 40% for the combination. So there's definitely additive effect and improvement when you combine them together. So it does improve the erythroid response compared to just giving lenalidomide alone in this population. Another study that I would really like to highlight is a study in 2021 from Dr. List and colleagues. And what we actually found here was 195 patients with low-risk MDS or non-proliferative CMML other than MDS with del5q that had symptomatic anemia. Either they were transfusion dependent or they had a hemoglobin of lower than 9.5 grams per deciliter, or those that had failed to respond and lost response with erythropoietin were actually then treated with lenalidomide and erythropoietin alpha compared to lenalidomide alone. And if you look at the major erythroid responders, it was actually significantly higher, 28% with lenalidomide plus EPO compared to lenalidomide alone was 11%. And this was highly statistically significant. So let's go over also quickly the HO189 phase 2 trial, which is a combination therapy of lenalidomide with ESAs and G-CSF. So, we've talked extensively about anemia, but I think one thing we have to recognize is that our patients with MDS could have cytopenias in other cell lineages as well, like neutrophils, platelets frequently. So this is something that is also still at this point poorly addressed in clinic, but I think we could provide more supportive care. So in this trial, 184 patients, 84% of them were non-del5q, 16% with isolated deletion 5q were enrolled with a median follow-up of 70 months. And in the arm A, which was lenalidomide alone, and in arm B was basically lenalidomide with ESAs and plus or minus G-CSF, we found that 39% and 41% of patients respectively achieved the hematologic improvement in the erythroid lineage. The median time to the hematologic improvement erythroid in the lenalidomide alone arm and the other arm too was about 3.2 months, and the median duration of this response was about 9.8 months. And we did find that lenalidomide induced hematologic improvement erythroid in patients that had across the board non-del5q as well as del5q without the addition of ESAs and G-CSF. So this is an interesting study. Here we don't see as much of a difference with the other studies that we previously discussed. Andrew, actually, I have a question for you. I think we went over your patient Margaret, and I'm sort of wondering, based on the results of the Sintra-Rev study that we reviewed, do you think that for this patient, would she have benefited if you had initiated lenalidomide when she was still transfusion independent? Is this something you would consider in your clinical practice?
Yeah, I mean, I think that's very interesting. I think of, historically waiting for lenalidomide until patients are requiring transfusions, but perhaps the idea of not waiting for that to occur and maybe initiating early may be able to buy them some leeway, so some lead time, really, where they can kind of avoid going down that route of needing transfusions, as we know that can be really life-altering. Do you routinely check for actionable events like the presence of a p53 mutation and a variant allele fraction before initiating lenalidomide or at any points during therapy with lenalidomide?
Absolutely, Dr. Kuykendall. So, I would say that before we initiate any therapy for patients with myelodysplastic syndromes, a very important part of our workup is really getting next generation sequencing. We do get a targeted molecular profile of the most frequently expressed myeloid mutations in MDS and AML. We also get, of course, a karyotype and FISH. And my personal practice is to repeat this at any bone marrow time point for patients and also every 6 months from their peripheral blood. So I do keep a track of their clonality, which could include TP53 mutations and variant allele frequency of the mutations that patients have.
Thank you so much. That's an absolute wealth of information. And so just kind of trying to recap what I learned from you today, which was really the treatment with lenalidomide is indicated in patients who have low-risk MDS, who harbor this del5q abnormality and may have improved outcomes when initiated prior to transfusion independence, maybe different than what we used to think about. Exposure to thalidomide analogs, particularly lenalidomide, is associated with an increased risk of TP53 mutated myeloid neoplasms. And to keep an eye on that may warrant monitoring these mutation status and NGS panels, especially when we know that there's the presence of a p53 mutation at initiation of treatment. So thank you, Dr. Shastri, so much. As I said, a wealth of information.
It's my pleasure, Dr. Kuykendall.
Thank you for joining us for this Phone a Friend program. Please remember to take the post-test and fill out the CME evaluation. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com. You can view other low-risk MDS Phone a Friend episodes on the series landing page.